Thank you so much for joining us, and welcome to all of our participants today. We are joined here for the webinar, Learning Through Implementation, Reaching First-Time Parents and Young Married Women in Burkina Faso. My name is Margot Fonestock, and I'm a Program Officer in the Global Development and Population Program at the William and Flora Hewlett Foundation in Menlo Park, California. This webinar will share some very recent and fascinating program experience from Pathfinder International, who developed a unique initiative to specifically reach young married women with contraceptive information and services in Burkina Faso. And as you'll hear from the presentations, the majority of births to adolescents actually happen within marriage. And so there are, as you all know, enormous health benefits to delaying a first pregnancy or spacing first and second birth. And there are also a host of complicated dynamics when trying to reach young married women in Burkina Faso with contraceptives. And I think you'll find this discussion today very interesting in how this project adapted its program in real time to address those complexities. But before I introduce the speakers, please note that we will have a question and answer session after the presentations, and we'll be accepting questions throughout the presentation through the questions box in your webinar window. You'll also have a chance to submit questions later during the discussion, but please feel free as you think of them along the way to submit questions as they come up. And we'll try and get to as many as possible at the end. So we are privileged to have with us three speakers today. Our first speaker, Callie Simon, is the Senior Technical Advisor for Applied Learning in Sexual Reproductive Health and Rights at Pathfinder. Callie is based in Pathfinder's Washington, D.C. office. And I should just add, we're happy that she's there today, given the busyness in D.C. today with the Pope's visit. And Callie supports Pathfinder's projects and country programs worldwide. She'll set the stage for us with the webinar, talking about the importance of young married women and first-time parents and their unique needs and the challenges that they face, and talk about the previous projects and evidence that informed the design of this project in West Africa. Next, we have the privilege to hear from Dr. Abdul Balde. Dr. Balde is the interim country representative for Pathfinder in Burkina Faso. Dr. Balde will describe the project's design, the implementation process, and the quantitative results that they saw. And finally, Katie Chow is the Evidence to Action Project's Senior Youth Advisor for Pathfinder and is based in Senegal. And Katie joined Pathfinder's Evidence to Action Project in January this year, and she manages a portfolio of adolescent and youth reproductive health projects with a focus on West Africa. Katie, at the end, will speak to the implementation learning process and the key findings from this project that can really contribute to the evidence base for first-time parents and young married women. So without further ado, Callie, I'm going to turn it over to you, and the floor is yours.
Great. Thank you, Margot. As you mentioned, today I'll begin with a brief overview on why we should be investing programmatic resources into the health of young married women and first-time parents. And I'll present some information about their unique needs, challenges, and the existing evidence that we drew on to design a project focused on young married women and first-time parents in West Africa. Next slide. Let's start with who first-time parents and young married women are. For the purposes of this webinar, and for many other ongoing technical discussions happening now in the SRH community, we are defining young married women as young women under the age of 25 who are married. And we are defining first-time parents as young women under the age of 25 who are pregnant or have one child, regardless of their marital status, and their partners or husbands. Now, why should we invest in the reproductive health and the well-being of young married women and first-time parents? Next slide. First, they are a large and important population. In fact, 1 in 3 women in low and middle income countries are married by age 18. And that number is even higher in many places, such as in the several countries in West Africa, where our webinar is focusing today. While programming to prevent early marriage is critical, programming to meet the needs and address the unique vulnerabilities of these married adolescents is equally as important. Next slide. Secondly, as Margot mentioned, the vast majority of adolescent childbearing happens in the context of marriage. So while not all first-time parents are married, most are. And this time period, when adolescents begin childbearing, is a critical time for intervention to improve health outcomes. In addition, married adolescents are using contraception, but few married adolescents are using contraception. Recent DHS surveys show that in more than 2/3 of the countries in Africa, contraceptive use among married adolescents was lower than 20%, and much lower than that in many countries, including in West Africa. Promoting healthy timing and spacing of pregnancies, that is, supporting young married women to delay the first birth until at least age 18, and engaging with first-time parents to space the second pregnancy by at least 2 years, will improve maternal and infant health outcomes. In addition, promoting healthy timing and spacing of pregnancies and increasing access to contraception among this population will help uphold young women's right to access contraception and other SRH services, and will help countries progress and meet national family planning goals. Furthermore, getting married and having a child are important moments in life. It's a time of major changes in roles and responsibilities in a household. And it can also be an important window of opportunity. Emerging evidence from Pathfinder's projects and projects of other organizations suggests that this moment, when a couple is married or a child is born, can be a moment where interventions can support changes in gender norms in the household. And this can translate into changed gender norms between the couple in terms of decision-making power or roles and responsibilities. And it can also be a time where interventions can successfully help change norms to support more gender-equitable child-rearing practices. For example, supporting couples to think about having their boys and girls share chores in the household, or setting girl children on a path to education. Young married women and first-time parents have clear health needs, and it can be an important moment for intervention to dramatically improve health and gender outcomes. However, this population also faces substantial barriers to delaying and spacing pregnancies and accessing the contraceptive and other health services they need. A review of the literature and experiences of Pathfinder and others suggests that these barriers can be seen at the structural level, the social level, and the individual level. Next slide. At the structural level, young married women and first-time parents may be far from healthcare providers and may have restrictions on their mobility, such as not being able to go out of the house unaccompanied. In addition, once a young married woman or a first-time parent reaches a provider, many experience the negative effects of provider bias, where providers, for example, don't counsel young married women without children on contraception, or bias that makes providers encourage first-time parents to have another child very quickly. In some cases, that bias may also prevent a provider from counseling on a full range of methods, meaning that providers may often exclude important methods such as long-acting reversible contraception. Opportunity costs can also be a substantial barrier for young married women and first-time parents, as they have roles and responsibilities of the household like cooking, getting firewood, getting water, caring for their children, and the costs of leaving these behind may be too great for them to seek services. Young married women and first-time parents may also be unwilling to seek services due to limited privacy and confidentiality at the facility. They may be afraid of their families or communities hearing them or seeing them seeking contraceptive services. And this dovetails with some of the social barriers I'll mention in a few minutes. Requirements for third-party consent, such as husbands or parents needing to consent for the wife to get contraceptive services, are still found in many places and clearly pose a formidable barrier. Finally, for first-time parents in particular, family planning integrated into child health or maternal health services would significantly increase access for these young women. Unfortunately, these types of integrated services are rarely found in many of the places where we work. Next slide. In addition to these structural barriers, young married women and first-time parents experience a range of social influences that promote early and frequent childbearing and create barriers for use of contraception and other health services. For example, pressure from communities, mothers-in-laws, the husband's family to have a child soon after marriage to prove their value as a woman or their value to the family, prove their fertility, are strong and important influences in young women's lives. In addition, due to a combination of age, social status, pervasive gender inequality, young married women and first-time parents are likely to have very limited decision-making power around contraception use, fertility, and timing of pregnancies. In many settings where son preference is strong, the literature indicates that women and girls are more likely to have multiple pregnancies within a short interval if their first child is a girl, creating another social pressure for these populations. In countries or regions where polygamy or multifamily compounds are common, co-wives can also play an important role in influencing whether young married women and first-time parents use contraception. As you'll hear later in this webinar, the pressures and influence of these co-wives can actually vary quite dramatically across contexts and settings. In some cases, the presence of co-wives may make young married women or first-time parents feel pressure to bear multiple children or bear a male child to compete for attention or favor from the husband. Lastly, many young married women and first-time parents move to live with their husband's family upon marriage or childbearing, and they leave behind a family where they grew up and their existing social networks. Without this social support network, they are left vulnerable to navigating a complex new world alone and may not have the kind of support they need to make decisions or negotiate for their health and well-being. Next slide. At the individual level, young married women and first-time parents also face a range of challenges. Girls who marry early, and therefore who are young married women or first-time parents, typically have lower levels of educational attainment, have limited social networks, as I mentioned, have restricted mobility, and have had very little access, most likely, to comprehensive sexuality education. They are unlikely to have knowledge about healthy timing and spacing of pregnancies, about contraceptive methods, and they may harbor myths and misconceptions about contraceptive methods. Further, as I described previously, this combination of their lower social status, their young age, gender inequalities exacerbates unequal power dynamics and limits their autonomy and self-efficacy in making decisions to seek services or space or delay pregnancies. Finally, the social norms I described that frown upon the use of contraception can contribute to a fear of being seen seeking services, and the social norms that are supportive of early and frequent childbearing make it so that many young married women actually want to have a child. And this is an important dynamic for us to consider in our programming for this population. Next slide. While the importance of working with young married women and first-time parents is clear, there are very few projects focusing on this population, and this is particularly true in the West Africa region, where extremely high rates of early marriage and adolescent childbearing make working with young married women extremely important and urgent. Recognizing this gap, in 2012, Pathfinder decided to design a project for young married women and first-time parents in 3 countries, Guinea, Niger, and Burkina Faso. Our presentations today will focus on the Burkina Faso work, which was funded by Pathfinder's privately raised board-controlled funds, the Hewlett Foundation, Templeton Foundation, and the Weyerhaeuser Foundation. To design this project, we partnered with our local implementing partners, and we looked closely at the barriers I just presented and how they manifested in the Burkina context. In addition, we used learnings and evidence that Pathfinder has generated over the course of more than a decade of implementing programs for first-time parents and young married women in different contexts. As well, and we drew on the recommendations from the Evidence to Action Project in a recent literature that they conducted on first-time parents, and that can be found on their website. I'll now speak a bit more about the evidence from the other projects that we used to inform the design of the West Africa project. Next slide. 2 of the projects that we learned from were the Prachar project in Bihar, India, and the Gender Roles, Equality, and Transformations project, or the GREAT project, in northern Uganda. Prachar was implemented for 10 years in Bihar with funding from the Packard Foundation and UNFPA in the 3rd phase. And through 3 rounds of evaluation and a recent evaluation of sustainability, we saw that Prachar had a significant impact on contraceptive use among young married women, young married couples, and first-time parents. The GREAT project is led by the Institute for Reproductive Health at Georgetown University and was designed and implemented in partnership with Pathfinder and Save the Children with funding from USAID over the last 5 years. Recent GREAT evaluation data suggests that exposure to the project did increase young married women and first-time parents' use of contraception, as well as improving attitudes around key SRH and gender outcomes. To design the project in West Africa, we reviewed the implementation processes and the evaluation results of these 2 projects and identified some key programming principles that we felt were important to apply in our adaptation of this programming to West Africa. Next slide. First, both GREAT and Prachar demonstrated the importance of tailored age and life stage specific programming. In this case, that meant that we specifically targeted the young married women and first-time parents, and that we developed content specifically tailored for their unique needs. Secondly, both grade and Prachar were gender synchronized in that they engaged both males and females, the husband and the adolescent girl, simultaneously in programming. Under Prachar, in fact, quantitative evaluation results showed significantly stronger outcomes when both the husband and wife were exposed to the project. And we used this programming principle in designing the West Africa work. Both Gray and Prachar demonstrated the importance of engaging mothers-in-laws and key gatekeepers or key decision makers in the lives of young married women and their partners. And Prachar showed us how important home visits could be to reach young women with information and services when they have limited mobility and high opportunity costs for leaving the home. Building on this, and in addition to this, the GREAT project added to our understanding of the use of small groups to engage young married women and first-time parents and their partners, and the use of small groups to foster reflection and dialogue that could help shift gender norms and build the social capital of adolescent girls. In both GREAT and Prachar, we saw the importance of linking with quality SRH services, including postpartum contraception, and integrating contraception counseling and provision into other MCH services. And this was another important programming principle that we used in the design of the West Africa work. Next slide. Though we did design this project in Burkina Faso and in West Africa based on the considerable learnings from our project programming experiences and based on a review of the literature that Evidence to Action did, we were also very aware as we designed the project that there was a lot that we didn't know. There was a lot we weren't sure about in adapting the intervention approach to the Burkina context. We were also very aware that globally there's a fairly limited evidence base in relation to first-time parents and young married women, and that there's a need to build that evidence base through both rigorous research but also examination of the process of implementation, the process of adaptation, and generate evidence through those mechanisms. So we invited the Evidence to Action project to partner with us to help us generate these kinds of learnings, to look carefully at the project's implementation processes, and to generate evidence from this experience to inform future program design in Burkina and in similar contexts, as well as to inform adaptations needed to both scale or to apply this work in other countries. Some of the key questions that we wanted to learn that were sort of swimming in our minds as we were designing the project was how exactly to adapt the learnings and the evidence from the global setting to the local Burkina context, whether or not we needed to do both small groups for adolescent girls to build their social capital and complement that with home visits, or whether one might be a more effective or appropriate strategy. And we also had questions around how to effectively engage with different gatekeepers in the lives of young married women and first-time parents, like co-wives, or in the case of Burkina, or husbands or in-laws. And so we had these questions kind of swimming in our mind. We designed the project, and I'll now turn it over to my colleague, Dr. Balde, who will share with you how the project was designed, how it was implemented, the implementation experience, and some of the quantitative findings from the project, as well as some of the constraints that informed our implementation learning process that we conducted with Evidence to Action. So thank you, Dr. Balde. Take it away.
Thank you, Kali. As Kali mentioned, we use the learnings from Pathfinder's other projects and E2A's FTP literature review, and then applied that learning considering the unique context of Burkina Faso. Next slide, please. This is adolescent life in Burkina Faso. Mainly, they give birth within the context of marriage, early and frequent pregnancies leading to shorter birth to pregnancy intervals, socially isolated and also isolated from their traditional network, the lack of power to negotiate their reproductive life, like the decision to choose when and if to have children, and also there are frequent polygamous marriages. Next slide, please. So this slide shows that there is a lot of early marriage in Burkina Faso. At least 50% or girl get married before age 18. Next slide. Here we can see that the CPR is very low in the group of age 15-19. Next slide, please. The program design. Let's say that this project was conducted for 2 years, from June 2013 to May 2015, in two health districts in Burkina Faso, Nongre-Mason and Diapaga. And we implemented it through two CBOs, two local partners, which is Bukaso and SOS. But we also partnered with the public health system at national, district, and health facility level. The program was designed to respond directly to the barriers at individual, social, and structural level that Kali mentioned earlier. This was designed as a small-scale project to assess appropriateness, feasibility, and generate learning to consider how to adapt and scale up. Next slide. What were our interventions at individual level? To address individual level barriers, we conducted the home visits by animators. They were male and female. They were trained on sexual and reproductive health and Pathfinder supplemental training on HTSP. They were also assigned to conduct 6 home visits to each young married woman. They were assigned to make referrals or accompaniments to health facility when needed. Another intervention was CBDs of contraception commodities, pills, and condoms. Next slide. At social level, small group meetings held monthly by trained peer leaders using grid project activity cards for reflection and dialogue, allowing young married women empowerment. Community meetings and theater fora were also held. Now, to engage key influencers and other stakeholders like mothers-in-law, husbands, and religious leaders, animators conducted home visits. Next slide, please. At structural level, Pathfinder collaborates with the MOH to support them develop or update their national adolescent and youth sexual and reproductive health strategy. And also Pathfinder supported our local partner, which is Bukaso, to organize a workshop. That workshop brought together all partners and stakeholders to share Pathfinder experience and all other best practices organizations or other partners are implementing in Burkina Faso. What we did also, Pathfinder conducted facility assessments like a baseline, because at the beginning of the project we decided to create a youth-friendly services. So we conducted assessments, and then we held a workshop to develop improvements plan for these health facilities. After that, we trained service providers. We provided them with equipment and also with some commodities, basic commodities and basic equipment. Next slide, please. What were the key tools and resources we developed, and we adapted some of them? All were around gender norms, young woman empowerment, HTSP, and good practices. So we developed the supplemental training curricula for healthcare providers, animators, and in talking about the animators curriculum, we added a supplemental and additional curriculum for just community health workers. So they participate to the training, the last day of the 3 days training. And then also we adapted the grid project activity cards in Burkina Faso context. Next slide, please. Here are our key achievements. As you can see on this slide, we trained animators, peer educators. We enrolled more than 600 young married women, our main target population, and we trained also peer leaders. We trained peer leaders, and we set up 40 small groups for young married women, and we conducted approximately 2,000 home visits. On your right, you can see a chart describing what was our result at the beginning of the project. When we conducted the basic assessment, we found that the number of young married women saying, yes, I am currently using contraceptive method was 41%. And then at the end of the project, we conducted another assessment, and we found that the number of young married women saying, yes, I am using doubled. But however, I have to mention that they may have been introduced some beer here because for two reasons. The first reason is that young married women can say yes because they may think that this is the answer perceived as good by animators. The second reason is that even animators can introduce a beer because they can think that this is that will reflect their performance because they conducted all counseling over the project. Next slide, please. Generating learnings through implementation. As Kali noted previously, beyond just the quantifiable outputs of the project, Pathfinder was interested in learning through this implementation, and we invited E2A to partner with us to do that. As we invited the E2A to work with us, however, a few things were clear. We wanted to learn, but we had some constraints in terms of resources, staff, and timeline to deal with. That means that we had to work with them to figure out how to embed learning and documentation in my existing management processes. In addition, Pathfinder had a growing interest in capturing the perspective and tacit knowledge of our frontline implementers in our projects. So we were interested in how to reach young married women FTP and why these techniques were effective or not, drawing on the question that the field of implementation science is encouraging us to ask. Now, I will hand the presentation over to my colleague, Kati Chow from Pathfinder's E2A project to talk more about E2A's findings. Thank you.
Thank you, Dr. Balde, and good day or good evening to everyone joining us online. As Dr. Balde mentioned, Pathfinder invited the Evidence to Action project to design an implementation learning and documentation strategy for this Burkina Faso project. So my presentation will focus on the design and the results of the strategy. Next slide, please. At the time that Pathfinder designed the Burkina project, very little evidence existed about effective strategies for the healthy timing and spacing of pregnancies for first-time parents, especially in the West African context. And recognizing the need to enhance the knowledge base about effective programs for first-time parents, the Evidence to Action Project and Pathfinder design an intensive implementation, learning, and documentation strategy. And the objectives for this strategy are outlined on the slide. The strategy was also designed to address the limitations of traditional process documentation approaches, where data collection and analysis are usually conducted as add-on activities, and frontline implementers are only involved as sources of data. In our strategy, frontline implementers were generators, analysts, and users of their own evidence from their own implementation experience. And I'd like to underline here that the strategy was designed to identify context-specific learnings, and this is specifically for the Burkina Faso context. Next slide, please. At the heart of the implementation, learning, and documentation strategy were the implementers themselves, and these were the project's community-based animateurs and the small group leaders. Routine monthly group discussions led by Dr. Balde were conducted between October 2014 and March 2015. And discussions were also held with the two implementing partners, both Burkina and SOSJD. Pathfinder and E2A developed specific topic guides for each group discussion, and the guiding questions systematically examined how the implementers reached young married women, including first-time parents, how they engaged key influencers and gatekeepers, both at the household and community levels, and why certain approaches were more effective than others. In the early group discussions, a broad focus, in the early group discussions, we had a broad focus on the processes and the techniques used by implementers, as well as their successes and their challenges. And as key themes and insights emerged about implementation, the discussion guides and questions were refined, thereby enabling the focus of the discussions to evolve in response to implementers' own evolving reflections. The qualitative data from the group discussions was analyzed on a monthly basis by Pathfinder and E2A. And this process enabled the project team to formulate preliminary hypotheses about effective strategies for reaching young married women, including first-time parents, in the Burkina Faso context. And finally, at the close of the implementation phase in April 2015, culminating group discussions were held with animateurs and small group leaders, and this was to help validate the hypotheses. Next slide. Several key findings emerged from the implementation, learning, and documentation strategy. So for the remainder of my presentation, I will focus on three main topics of the findings. The first is how to engage key influencers and gatekeepers. The second, how to effectively plan and run peer group discussions and home visits. And third, how to tailor specific approaches to increase demand for contraceptive services amongst young married women, specifically first-time parents. And the other findings from this documentation and implementation learning process are outlined in two technical publications, both which are and will be available on the E2A and Pathfinder websites. And a link will be shared through the chat box for these publications. Next slide, please. So as Callie mentioned, findings from previous projects suggested that in order to reach young married women, programs should target those who influence their decision-making ability. And in the Burkina Faso context, this includes mothers-in-law, husbands, and co-wives. The frontline implementers of this project identified mothers-in-law as important stakeholders, not only because they hold influence over young married women, but also because they hold influence over other gatekeepers, including husbands and co-wives. The implementers found that several strategies were effective for positively engaging mothers-in-law. It was first important to approach mothers-in-law individually at the beginning of outreach interventions, and particularly prior to speaking to the young married women. And generally, this approach made the mothers-in-law more receptive to home visits. The frontline implementers also noted differences between the peri-urban and the rural project sites in terms of mothers-in-law's attitudes towards the use of contraceptives. So in the peri-urban project site, Nongre-Massam, mothers-in-law were more open to their daughters-in-law using contraception, but they still lacked correct information about contraceptive methods. On the other hand, in the rural project site, Diapaga, Mothers-in-law largely disapproved of their daughters-in-law using contraceptives, and this disapproval was mainly rooted in prevailing cultural and gender norms that favor large families, but also because they lacked information about contraceptive and other sexual and reproductive health services. Therefore, the implementers adapted their approaches when engaging with mothers-in-law to their specific preferences and their needs. So, for example, in the peri-urban project site, mothers-in-laws preferred having discussions with older animateurs and those coming from the same neighborhood, rather than speaking with younger animateurs or those from outside the community. And in the rural project site, some mothers-in-laws were more receptive when discussions were carried out with the support of a traditional or religious leader. Next slide, please. Involving husbands or male partners was an important component of the Burkina Faso project design, and strategies for engaging men included encounters during home visits as well as at community events. However, the animateurs found that very few men were available when they conducted their home visits. So they adapted their strategies to proactively reach out to husbands, either in their places of work, their places of leisure, or at moments when they were more likely to be at home. And this was found to be more challenging in the peri-urban project site, where there were fewer structured community gatherings for men compared to the rural project site. The frontline implementers also reported that the age gap between spouses had an impact on how to involve husbands in home visits. So when there was a large age gap, this contributed to an unequal power dynamic that made it difficult for the young woman to express herself openly. And older husbands also didn't feel comfortable themselves to discuss personal matters in front of a third party, including the animateurs. So the animateurs found it more effective to speak to older husbands and their young wives individually. For couples who were close in age, couples counseling was found to be an effective strategy for engaging the younger husbands. In addition, the frontline implementers found that involving supportive mothers-in-law and supportive religious leaders was effective to facilitate contact with husbands and to engage them in constructive discussions. Next slide. Callie also mentioned the importance of taking co-wives into consideration for first-time parent programs. And the frontline implementers of the Burkina Faso project stressed the importance of first gaining a clear understanding of who co-wives are before being able to assess the influence they have over a young married woman or a first-time parent. In Burkina Faso, co-wives extend beyond women who share the same husband to also include sisters-in-law, cousins, and other older women in the household. And all of these women were found to hold significant influence over a young married woman. The frontline implementers noted differences in co-wives' influence in the rural project compared to the peri-urban project sites. In the rural project site, animateurs observed that co-wives were more often supportive of young married women participating in the project, so long as the older co-wives were treated courteously. On the other hand, in the peri-urban project site, the animateurs observed that co-wives were more often obstacles. They often feared that if a younger co-wife used contraception, she would become more available to satisfy her husband's sexual needs and therefore become a favored co-wife over others. The animateurs also observed jealousy when older women thought that the co-wife would receive gifts through the project, which they wouldn't be eligible to receive. So in such cases, the frontline implementers found that it was useful to speak to co-wives individually and clearly explain why the project worked with young married women, stressing the age criteria. And sometimes animateurs also held counseling sessions with the older co-wives to show them that they were a valued stakeholder in the project. However, the data from these counseling sessions was treated separately from the data that was generated from the visits with younger co-wives. The small group leaders also found that occasionally inviting co-wives to participate in the small peer group sessions helped to reduce reticence amongst co-wives. Next slide. So generally speaking, the Burkina Faso project highlights some important lessons learned for engaging key influencers and gatekeepers. First, it's important to involve key influencers at the start of the project and always in a courteous and a respectful manner. Second, it's important to invest human resources and time to create a trusting environment for these key influencers. Third, the experience really stresses the importance of unpacking the diverse relationships that a first-time parent or a young married woman may have with her household influencers. So for example, the diverse relationships between co-wives are important to examine in order to adapt approaches for home visits and small peer groups. And it's also important to explore the relationships that mothers-in-law have, not only with young married women, but also with the other key gatekeepers and influencers in a household. Fourth, while the frontline implementers found that it was important to involve key influencers in the project, their involvement also made it more difficult for frontline implementers to guarantee confidentiality for young married women and first-time parents. Many women in Burkina Faso, including young women, don't want their husbands to know that they're using contraceptives. So while it was important to involve husbands as much as possible, it was also important for animateurs to respect the young married woman's wishes for privacy and confidentiality. And this trade-off between meaningfully involving key influencers while also maintaining confidentiality and trust with young married women is an important consideration for future programming. Next slide. In terms of lessons learned about how to plan and implement programs for young married women, including first-time parents in the Burkina Faso context, this experience confirms findings from previous literature, which suggests that combined approaches for reaching first-time parents and young married women are effective. The frontline implementers of this project found that conducting both home visits and small peer groups in tandem was effective to achieve project results. So the home visits were found to have the advantage of individualized attention and privacy, and they helped young women to ask questions that they felt too shy to ask in group settings. The peer groups offered a space for sharing and exchanging, and also fostered a sense of camaraderie amongst the young married women. Thus, the frontline implementers found that the two strategies were complementary. And when they were combined with supply-side interventions, including community-based distribution of contraceptives, the implementers found that this integrated strategy was effective for increasing access to contraceptive services. However, further research would be necessary to examine the individual effects of each component separately or combined differently in the Burkinabe context, since this particular project only implemented one approach to the combined interventions. Second, the findings of this project suggest that small peer groups can be an effective strategy for building young women's social capital and agency in the Burkinabe context. As I mentioned earlier, the group discussions created a safe environment for sharing experiences. And the creation of this safe space not only empowered young women to speak more confidently about sexual and reproductive health issues, but it also created an important social network for young married women and first-time parents. The findings from this project also suggest that enhanced integration with broader maternal and child health issues could further strengthen this combined approach. The project that we're speaking about today had a specific focus on contraceptive use for the healthy timing and spacing of pregnancies. Yet the frontline implementers mentioned that many young married women and their household influencers were also concerned about other maternal and child health issues. Thus, there's an important opportunity for greater impact if such projects integrate contraceptive information and services with a broader focus on maternal and child health during home visits, small peer groups, and for service delivery. Next slide. The frontline implementers from the project also found that different strategies were effective to increase demand and uptake of contraceptive services for diverse segments of young married women. So those without children, those with one child or first-time parent, and those with multiple children. So specifically for first-time parents, the implementers found that they generally had more interest in family planning than young married women without children, but they were still eager to have more children. The first-time parents were less comfortable to speak in group settings about contraception as compared to young married women with multiple children. But nevertheless, the first-time parents were very interested in hearing others' experiences in the small group settings. Approaches that emphasize the benefits of healthy timing and spacing of subsequent pregnancies were found to be the most effective entry point, both for discussions with first-time parents as well as with mothers-in-law. The small peer group leaders also found it was useful to invite first-time parents to bring their child along with them, which helped them to participate in the group discussions while also at the same time caring for their children. Next slide. So the findings from the Burkina project helped to fill knowledge gaps from existing literature. And the iterative approach to documentation with frontline implementers has brought to light some important conclusions for the Burkinabe context. First, combining small peer group discussions, home visits, and quality improvements to health service delivery is a viable approach for reaching first-time parents and young married women in Burkina Faso and potentially other West African contexts. Second, future programs for young married women and first-time parents should aim to apply a comprehensive approach that integrates contraceptive information and services with maternal and child health information and services. Third, mothers-in-law should be prioritized as a direct target group, and strategies should be developed not only to build their support for the project, but also to engage them to influence other household gatekeepers. Fourth, strategies for engaging husbands should take into consideration the age difference between spouses and adapt accordingly. And engaging husbands requires a proactive approach to reaching them in their usual areas of work or leisure, in addition to reaching them at home. Next slide. Fifth, the diverse relationships between co-wives should be considered and examined in order to design the most suitable strategies for building support among co-wives and also for reaching young married women effectively. And the mechanisms to encourage co-wives to directly participate in programs should be established while also ensuring privacy and confidentiality for young married women, including first-time parents. Sixth, when recruiting frontline implementers, emphasis should be placed on selecting people with a profile and skill sets that can inspire trust amongst community members. Seventh, in order to build young women's social capital, including through supportive peer groups, it's important to consider strategies that will prioritize the inclusion of first-time parents and young married women in these types of interventions. And eighth, engaging frontline implementers in implementation learning and documentation was not only effective for generating evidence about how best to reach first-time parents and young married women, but also provided an opportunity for continuous learning and improved project implementation. So these approaches should be integrated into future programs for young married women and first-time parents in order to better address the gaps in the knowledge base, as well as to improve the effectiveness and quality of interventions. So thank you very much.
Great. Excuse me. Thank you, Katie, Dr. Balde, and Callie for these excellent presentations. And really for those of us interested in how to reach young women with contraception, and particularly how to do that in a context like Burkina Faso and in the rest of Francophone West Africa, I think these presentations provided some really useful lessons. So before we move to the question and answer portion, I wanted to highlight one thing that I found particularly interesting about this work in Burkina. So I hope you on the line were able to hear and really understand that this project had the opportunity of leveraging Pathfinder's role in the USAID Evidence to Action Project. And what that meant was that the collective team working in Burkina was able to learn by doing, and they really made some real-time course corrections in the program. And as you all know, I think you all would agree with me that it's not often in public health with the way most of our projects are structured, which are usually according to work plans and log frames, that we really have the chance to use an iterative and a client-centered process to arrive at the right solution. And so just one example that Katie just shared in her presentation was when the project better understood the dynamics between the co-wives and how this was really different between the rural areas and the peri-urban areas, that the project was able to quickly modify its approach and really take those dynamics into account. And so I think it's a reminder, particularly to us donors, that we should think about how to structure these types of projects that really tackle very difficult to solve challenges and allow for more flexibility and more dynamism when really often the best approach we cannot fully know or understand it at the outset of a project. So I think that that was one of the really valuable lessons about this experience that we just heard about. So I actually have a couple of questions myself that I'll ask our speakers now as we wait for more questions to come in from participants. And just as a reminder, remember to use the questions box on your screen to submit your questions virtually. So I'm going to start with asking a question to Callie, our first presenter. Callie, you mentioned that the data trend from this project in Burkina was generally in a positive direction. So we saw generally a self-reported uptake in contraceptive use. So what do you think is needed now to more fully explore and understand the efficacy of this type of program in increasing contraceptive use? Is it more program experience at more scale, or do you think it requires a more rigorous evaluation now that the program has evolved a bit? So, Callie, over to you.
Thanks, Margot. And you're right. I think that the data from what Balde was sharing with us in terms of the self-reported contraception use and then data from health facilities do show that we're seeing kind of a trend in the right direction, but there's a lot more we need to know. And I think my short answer to your question is probably that we need both. I think what would be a good important next step is to use a lot of the learnings that we've generated to adapt the program and implement it at a larger degree of scale. But one thing that we learned from this implementation, and which you so nicely highlighted, and the field of implementation science clearly tells us, is that interventions will work differently in different contexts. And by context, I'm not just meaning Burkina versus Uganda or versus India, but within Burkina. And I think a lot of what Katie shared highlights that. And so as we think about going to scale, which we would certainly like to do, we would want to build in a continued ability to more rigorously understand context and an ability to adapt the intervention as we scale. In addition, I think that coupling that higher level of scale with a more rigorous evaluation to look at effectiveness, or perhaps, as Katie suggested, compare different models or different implementation combinations of interventions like the home visits versus small groups, as well as adding in that sort of continuing implementation science component will help us understand more about how to reach first-time parents and young married women in the Burkina context and why we might see effectiveness or not effectiveness at scale.
Great, thank you, Callie. Katie, this next question is for you, and I found really interesting. I know that the Evidence to Action Project actually used ExpandNet's beginning with the End in Mind tool to assess the scalability of the First Time Parents program. I think it's really exciting, given that this approach has potential to really meaningfully increase contraceptive use, particularly, as we've said, in this context in Francophone West Africa. So this question of scale, I think, is really, really critical. So just curious if you could share with us what these results showed from that assessment. Do you think it's a scalable model, or do some of the nuances in the program, as we were just discussing with Callie's intervention, the co-wife dynamic and a lot of the things that are really different from context to context, do those aspects make it more difficult to scale? Katie.
Great, thanks, Margot. Yeah, so as you mentioned, E2A used the ExpandNet beginning with the End in Mind tool to assess this small-scale intervention. As Balde mentioned, it was a small-scale project. And the beginning with the End in Mind tool outlines 12 recommendations to facilitate scale-up of health interventions. Overall, the assessment for this Burkina project showed that the project was well suited for scale-up, taking into consideration these 12 recommendations. So, for example, some of the more positive factors that emerged from this project was that it engaged key stakeholders in a participatory process. The project tailored its interventions to the sociocultural and institutional settings, and this was largely facilitated through working with the local partners, as well as having that a strong focus on adapting the project strategy to the context in Burkina Faso. Equally, the project was tested in a variety of settings, so working both in the rural and the peri-urban settings, which was enabled the project to basically say that it is viable for diverse contexts within Burkina Faso. And then the strong focus on documentation and the dissemination and promotion of learnings will also help to facilitate any future scale-up. But there were some areas that kind of were flagged for improvement from this scalability assessment. So one of the recommendations from ExpandNet is to keep interventions as simple as possible. But what we found in our assessment was that the supply-side interventions, particularly for this project, were fairly complex, and this led to some difficulties that would need to be addressed. So, for example, the role of the government community-based distributors of contraceptives, as well as the health facility providers, their role wasn't consistently understood in all the different project sites. And this resulted somewhat in a disconnect between the community level interventions and the service provision side. So if the project were to be scaled up in the future, further reflection would need to be done to simplify this service delivery component, and efforts would also have to be put into place to ensure more effective linkages between the community level interventions and the static health facilities. And also, as you mentioned, Margot, the need to adapt strategies to the nuanced roles of co-wives and other gatekeepers can lend to complexity for the intervention. So sufficient time would have to be invested, and as well as resources and training, to build the capacity of all the project implementers to assess these nuanced relationships, and then to also adapt the strategies accordingly. More information about the scalability assessment can be found in the report, so I'll leave it at that, but I'd be happy to take any other questions.
Great, thanks, Katie, and thanks, Callie, for answering those questions. Now I'm going to start reading questions from the participants that have been submitted virtually, and I'll ask our speakers to respond. And so a reminder to our speakers, if I ask you to answer something and you think someone else is better suited, please feel free to pass to your colleague. Dr. Balde, this first question is for you. So beware. This question is from Ann Feitzer. So Dr. Balde, if you look at your slide on the key achievements with some of the quantitative data that you presented, you said that there were 650 young women, young married women engaged in the project. And the question is whether those are the same women who report the use of contraception at the beginning and the end of the project. So the 41% to 81% increase that you include on the slide, does that represent the 650 young married women, or were there more women added as the project evolved?
All right, thank you for that question. We had a cohort, so we began the project with this cohort. There were more than 650. But at the end of the project, the last assessments were conducted with these 650. So at the beginning, we asked this question to the group, and at the end, the same question was asked to the same group. So meaning that we went through from 41% to 81%.
So it was the same women, Dr. Balde, is that right?
Exactly, the same women. The same.
Okay, great. Great. Thank you. So this next question is from S.J. Holcomb, and I think this would be a great question for perhaps Katie. Do you know if we have any data on the incidence of contraceptive use by the animateur, by the people who were doing some of the instruction? And in other words, did their commitment levels affect the willingness or the ability to conduct effective outreach to these young married women?
Thank you for that question, and it's a very interesting one. The project actually didn't collect data on the incidence of contraceptive use by the animateurs. So this was not really, definitely not a criteria for their selection, and it wasn't also tracked. Possibly on a similar line, though, of interest would be the role of the small peer group leaders who were specifically selected amongst the communities where the project took place, and these were also young married women themselves. And these were young married women often who had children. So it was very important to choose these young married women who could identify with the other young married women that would participate in the small peer groups. And what we heard anecdotally was that when these small peer group leaders were able to speak about their own personal experiences using contraception, it really helped to foster, let's say, a more open environment within the small peer groups, and it created an environment where the other young women were able to speak more openly. So unfortunately, we don't have the information about the animateurs, but it could be something to think about for other projects.
Yeah, I think that's a very good point. Very interesting question. Thank you, Katie. Dr. Balde, this next question I'm going to ask you to answer. This is a question from Baker Magwa. So his question is, back to the slide we were just talking about with the key achievements. So the key finding was that women in the group that you were working with increased, they said at least, that their contraceptive use increased from 41% to 81%. That seems like a very high percentage and very high prevalence, given that at the beginning of the presentation, I think it might have been in Callie's portion, that the CPR among, or maybe it was yours, Dr. Balde, sorry, the CPR in Burkina among this age group is very low, right? It's about 6% or 7% in this age group. So can you explain the very high use of contraceptives among this group that you are working with?
At the beginning.
Well, both even, right? Because 41% is very different than 6%.
Yeah, okay. Yeah, okay. Yeah, okay.
What is your instinct?
My thinking is that, we implemented this project in the area where our partner SOS was already working. Meaning that because of that, we think that that more young married women were already using contraception before we start our project. And then when we started the project, we conducted the trainings. We trained our partner participate to the training. Also, the frontline implementers participate to the training. And then they conducted counseling, home visits, and all activities at the individual structural, but also at social level. I think that intervention led to this performance. However, I mentioned the potential beer they may have introduced.
Okay, thank you, Dr. Balde. I think Callie has a few things she wanted to add to this question as well. Callie?
Yeah, thank you, and thanks, Dr. Balde. I think what you said is a really important answer and something that we all struggled with when we saw those numbers, to be honest. It's sort of a challenge for us to think about. One additional thing I'll just reiterate that Balde has mentioned is around the piece around the bias that we think might have been introduced by having the animateurs ask this question as part of their home visits. So this data was not meant to be used as part of a rigorous research or anything like that. It was data asked by the animateurs as part of home visits to inform their own counseling in the home visit, how they would approach that woman in the counseling. And so I think that we can probably understand that there is probably some preliminary use of contraception because of the other interventions that Balde explained, plus the introduction of bias by having the animateurs ask this question of the young women, and they think that the right answer is to say they're using. So I think we should sort of understand this in light of those very important limitations. We do think it shows a positive trend, which could be important, but we would certainly need significantly more and much more rigorous research to understand if this is actually a real effect that we're seeing.
Thanks, Callie. I think I'm going to hand this next question to you, actually, and if you think it's not appropriate for you, please feel free to hand it off to one of your colleagues. This is a question from Cheryl Turner, and Cheryl asks, what criteria were used to establish the peer groups? So what size groups did you find were most effective, and how much ongoing support was needed from the project to continue providing support to these groups over time?
Thank you so much for that question. I think Katie and I can maybe do that one together since she spent a lot of time understanding how those small groups were actually comprised. I know that in the beginning of the project we had defined some criteria for selection of both the small group leaders, which I think Katie already touched on a bit, and to invite young married women to participate in the small groups. And for participation in the small groups, the requirements were that the young married women were under the age of 25 and in fact married. Those were the only two main criteria. They could have been without a child, they could have a child, or be pregnant with a child. So they could be both young married women or first-time parents. And so those were how young women were invited. And I think that was the question. Yeah, for small group leaders, I think you already touched on it, but do you want to add anything to that, Katie?
Yeah, just to add, so the method that was used to identify these young women was to work with the government, the public health system's community-based health workers who were already in place in the communities. They know the communities very well. And the animateurs for this project, along with the peer group leaders, were in touch with the public system health workers to identify the households where these young married women live, and so they were able to more easily identify participants for the groups. The groups also, we aim to have about 15 to 16 participants in each. And just one thing I'd like to kind of highlight here, which was an interesting finding for this project, is that these small peer groups had a very high retention level. Often we see in youth interventions, especially with these types of peer interventions, you have a high level of retention maybe for the first or second meeting, and then participation tends to wane over time because people get busy or distracted with other things. Whereas in this project, in all of the small peer groups in all of the communities, there was almost 100% retention level. And this, to me, I find very interesting because it says that the project was doing something well and of interest and of value for these young married women. So I just wanted to add that little bit of information as well.
Thanks, Katie. And actually, I'm just going to ask you to keep talking because we have a question about this very similar vein, which is still about the small group discussions. This is a question from Ayana Batea, and she asks, can you please tell us more about the small group discussions, and is wondering how similar these are to the safe spaces approach that a lot of us have heard about, particularly working with young women, where young women meet to socialize, but they also get life skills training. So just curious if this is a similar approach or how you would distinguish this approach, if you would, between that and the safe spaces.
Great. Well, thank you for that question. I will actually pass this over to Callie because she was really intimately involved in designing the small peer group. So I'll let her answer that question.
Thanks, Katie. And it's a really good question. I'm just thinking about how we would distinguish. So I think the small groups were formed and as part of the design, drawing from a lot of the learnings from the safe spaces approach, which has been widely implemented and widely evaluated in our space, as the question asker mentions. And I think some of the findings from the safe spaces model shows the importance of these small groups for social cohesion, for developing these social networks, for building girls' confidence, for helping them develop negotiation skills. All of those reasons inform the formation of the small groups. I think one of the differences between at least some of the more traditional safe spaces approaches as they've been evaluated and as I've seen in literature, perhaps there are others that exist, and this model is that we really did focus the conversations around healthy timing and spacing of pregnancies, fertility, contraception, very much reproductive health. I think that the young women also brought up maternal health concerns, child health concerns, as Katie mentioned, but it was very much focused on health, less on literacy or financial savings or even things like violence, which I know sometimes the safe spaces models do include. So the content of these meetings, the way it was designed is that first the content was focused around these health issues, but what the topics were discussed were actually dictated by the young women themselves as part of the beginning of the meeting. The small group leaders were trained on all of these different topics and were provided with adapted activity cards that were originally developed for the Gender Roles Equality and Transformations Project in Northern Uganda. And those activity cards, which were developed by Institute for Reproductive Health and Pathfinder and Save the Children, were then adapted to this context of Burkina and were given to these small group leaders, and the small group leaders were trained on how to use them. Each activity card, by the way, these are available on our website if you're curious, in French and English, but each activity card talks about, addresses the different topic as it relates to reproductive health, healthy timing and spacing of pregnancies, contraception, gender, negotiation with a partner. And so each meeting, the girls could pick a topic topic, and they could do the activity in that card. These activities range from games that are sort of true and false games to learn about the facts of contraceptive methods, for example, to role play, to discussion about stories. Some of the cards include narratives or stories that girls can discuss and reflect on. And so each meeting they were able to choose one or two of these cards, or more if they really wanted to stay there, and use those cards to discuss those particular topics. I don't know, Katie, if you want to add anything to that point from what your discussions? No? Okay.
Okay, thanks, Callie. Great. Katie, did you want to add anything else?
No, I think Callie was able to cover everything.
Okay. Okay, Dr. Balde, this next question I'm going to ask to you. This is a question from Kate Lane. Kate asks if you can tell us can you tell us a little bit about whether the providers were receptive or accepting of addressing the needs of the young married women, or in the Burkina Faso context, we know that these issues, even for young married women, are still sensitive. Was there stigma with the providers? Can you talk a little bit about that? And then I have one more question for you, Dr. Balde, after you answer that question.
Yeah, okay. Of course, that is the training of service providers was really, really relevant because we knew that they constitute a barrier for young married women to use contraception services, because in West African culture, we cannot understand that a young married couple or young married woman can use contraception. So even the service providers constitute a barrier for that. So after that training, I have sent some testimonies from one of the service providers. They really accepted, they understood. They told us that it's the first time they learned something like this about young married women. And one of them told me, for example, that now she has many young girls sent by their own mother, and so that she can take care of them, and she can also console them, because she told us that really this is the first time he learned this approach.
Great. Okay. Thank you. And we know that providers, not just in West Africa, but in many places with young women, can be often the barrier. So it's good to hear that you're thinking about how to address that issue. So Dr. Balde, one more question for you from Kate Lane. Was there an effort in the program to increase access or use of the long-term contraceptive methods or long-acting methods, or did this project focus mainly on the short-term methods?
Yeah. Okay. We have already closed out this project, but we didn't. Long-acting method was not included in this project. However, if a young married woman wanted this method, she can access, because Pathfinder was not supplying contraceptives. Contraceptives were supplied by the government. So we explained during the training to the health service providers that all young married women or any woman can use the long-acting methods. But at the CBD's level, for example, they distribute the only pills and the condoms.
Okay, so part of it was the ability of the community health worker to be allowed to deliver those methods, it sounds like. Callie, thank you, Dr. Balde. Callie, I think you wanted to add something to this question as well?
Yeah, thank you. And Dr. Balde did a nice job of articulating, I think, the barrier is that, in fact, that at the community level, we were unable to provide LARCs because the government community health workers or CBD workers are only providing short-acting methods. But the healthcare providers were encouraged, as Dr. Balde said, during the training to counsel on the full range of contraceptive methods, and that, in fact, particularly in the postpartum period, and for women interested in spacing their pregnancies, long-acting methods can be an excellent choice. Something else I'll mention is that those activity cards that were used in the group discussions also include information and dialogue and debate and activities around all contraceptive methods, including long-acting reversible contraceptive methods. So they were included in that way as well.
Great. Thank you so much. And we just have time for one more question. So I'd like to ask this question. I think I'll start with Katie, but it might be interesting if all three of you, if we have time, could even give your opinion. So this final question is from Baker Magwa again. Thank you, Baker, for these great questions. He asked, are you able to identify the components of the intervention that were the most critical for the success of this program? So what's your instinct, or what's the evidence show us about which parts of the intervention were really most critical for the success? And so Katie, maybe I'll start with you, and then if Dr. Balde or Callie want to supplement, that would be great.
Great. Thank you for that question. Well, first let me kind of say the caveat that the documentation process, implementation learning process, and the scalability assessment didn't try to evaluate which of the components was more effective than the other. So what I will share is just, I guess, kind of more from some of, let's say, indirect data that came out of the work that we've done. But I mean, the first important finding, I think, is from the frontline implementers' perspective, the idea that both the home visits and the small peer groups are very complementary, and that implementing these two strategies in conjunction with one another allowed the project to respond to different needs for the young married women. So the needs in terms of privacy and confidentiality within the home visits versus the needs for social capital and social networking, as well as shared experience and learning from the small peer groups. So I think that those two strategies done in conjunction with one another was quite important. One of the components, let's say, across the board that was absolutely critical was training. Training of service providers, training of small peer group leaders, training of the animators. And this did come up in the scalability assessment as an important factor to consider in terms of bringing this approach to scale, and what the importance would be to have an emphasis on training, not only just on general youth-friendly service provision, but specifically for the realities and the needs of young married women and first-time parents. And this is an area that's a little bit more new for many of the partners working in this area. So I'll leave it at that, so I can pass over to Callie for her thoughts on the components that were most successful.
Thanks, Katie. And actually, I don't have much more to add except to say I think that there isn't the ability to, we didn't in this project have the ability to test, which intervention was most successful or most effective or most contributed to the outcomes. I think that there is an important opportunity to do so in the future, perhaps. I'm sorry, do you want to add something?
Yeah, sorry, just one more thing. This is Katie again, just to jump in, that the flexibility of the project and the ability of the project to kind of change and adapt based on the experiences that animators and peer group leaders were experiencing, this was also something that was really an important component. Mainly because not only are there significant gaps in the knowledge about how to most effectively address this population group, but beyond the knowledge gaps, just having that ability to kind of, as you mentioned, Margot, real-time adaptation based on real-time evolving context, I think this was also a really important component of the project.
And then I don't know if Dr. Balde wants to add anything.
Dr. Balde, I'd like to give you the opportunity to say if you have any thoughts about the question.
No, instead, I would like to add something about the challenges when you have such a project to implement. For example, the cost of contraceptives. We could not address that challenge until at the end of the project, because for young married women, for example, they advocated asking us to try to help them to access services, contraception services, long-acting methods, but with a low cost. That's what we couldn't. But even in Guinea, it's the same problem. So we couldn't address that question. meaning that I think if the contraceptives were free, for example, or low cost, we may have a best results at the end of the project.
Great, thank you. So it's true, the cost question, I think, particularly, as you said, with young married women and also in the context of Burkina Faso and probably in the other Francophone West African countries is probably a really big question. And I know it's something that partners like Pathfinder and others are thinking about, and as well as the Ministry of Health. So maybe an interesting question to for the future of this program would be, how would you assess which portions or which components of the intervention are the most successful? And which might be then brought to larger scale. So thank you so much for everyone's participation. I just want to direct your attention to your screen. We have a slide that gives Callie's email address, as well as a link to more information from the publication that Pathfinder just released on reaching young married women. And really thank you so much to Dr. Balde, to Katie, and to Callie for their presentations, and to all of you for your excellent questions and for participating today in this webinar. I'm going to conclude this session, and we hope that you would tune in again to another webinar in the future. Thank you so much.